Welcome to Healthcare Rounds. I'm John Marchica, CEO, Darwin Research Group. Today, I'm joined by two executives from South Shore Health, an independent integrated regional health system serving the greater South Shore community in Massachusetts. Dr. Alan Smith is President and Chief Executive Officer, and Dr. Samuel Ash is Chief Information Officer and Vice President of Information Technology and Innovation. Welcome, Dr. Smith and Dr. Ash. Thanks for taking the time to be with us today.
Thank you for having us, John. We look forward to it.
Well, let's start with some introduction. Maybe we'll start with Dr. Smith and just tell us about your role and maybe a little bit about how you came to be in the role that you're in the executive roles that you're in today.
Thanks, John. Yeah, my official title is President and CEO of South Shore Health, which is the parent organization of South Shore Hospital, plus all the affiliates, which we'll talk about. I am a primary care doctor by background. I practiced for 10 years as a full-fledged 24/7 PCP in the community north of Boston, and got early on very interested in the early days of capitation and even the business side of the practice, and got very involved with, at that point, Tufts Health Plan. And after 10 years of practice, was invited to join there to become a medical director. And I would say that was the hardest decision I've made in terms of my professional career, to leave practice. But I realized it was hard to do both and have a family with 4 kids. And so I made that decision and got involved in what was then Medicare Plus Choice, now Medicare Advantage, and then did strategy and business planning. And I enjoyed the insurance side, but felt I was more at home on the provider side, and ended up going to Brigham and Women's Hospital, where I eventually became president of the physicians organization. So that was what employed about 1,800 doctors. And I loved that. Plus, I was doing network, which was the Brigham's relationship with multiple hospitals, including South Shore Health. And in 2020, I was appointed presidency of South Shore Health. And again, I say to people, if you had asked me when I was in practice if you'd be a hospital president, I would have thought, gee, what are you smoking? Because this was never on my list of things I would do. But I am so happy here and love this role.
Great. Dr. Ash?
So I'm a pulmonologist and intensivist by training. I was at the Brigham for about 9 years, and actually there spent most of my time doing research. I worked in a lab that was a combination of pulmonologists and computer scientists. We did a lot of work on COPD, asthma, other diseases, built machine learning algorithms to analyze CT scans. It was a lot of fun. And clinically worked in the thoracic surgery ICU there. And I came to South Shore per diem back in 2019, just to pay for daycare, that sort of thing, doing nights and weekends, and then came here full time in 2022. Actually, initially as a full-time clinical role in the ICU here, and really loved it. And then in January of 2025, started as our chief medical informatics officer, focusing more on the EHR side. And then in July, stepped into the CIO role. And now I have a long title. I'm the Vice President of Technology and Innovation, and the Chief Information Officer. It gets kind of a mouthful. And similarly to Dr. Smith, if you had asked me, even a couple of years ago, if this is where I'd be sitting, I would have said, there's no way. But it's been fantastic, and it's really a tremendous opportunity. And it's been great working with Dr. Smith, the leadership team, but really all of our colleagues here to, as you said at the beginning, drive innovation and move the system forward.
Find it fascinating when I get physician leaders on the show, just to hear about their journey and why they made that switch, right? Because you invest all that time and effort into medical school. You probably enjoy providing care to patients, and it's a different world. It's a different a different day. And so it's always just, it's neat to hear how people came to these decisions and why they ended up where they are. So thank you for that. I wanted to start off by what's going to seem like a really simple question, but I wanted to get your sense on the term integrated and the word or the phrase integrated health system. one of the questions that I get asked a lot in my role here at Darwin Research Group is, what is an IDN or an IHS or these acronyms that get thrown around? But specifically, I'm interested in your perspective as an integrated system within the community and having that community focus. So maybe just we can start with Dr. Ash and come back to Dr. Smith. What an integrated health system means to you, but then what does it actually look like on the ground in the real world?
Well, I'll probably say sort of high level, and I'll let Dr. Smith speak to, a little bit more about the system in general. But I wanted to focus on one thing that you said, which was the community aspect. I think it's one of the things that I love most about being here. And I should say that in addition to my current role, I do spend about 20% of my time still in the ICU caring for patients directly. But I love the fact that we have this real clarity of purpose here, that the integration, everything that we do is focused on taking care of the South Shore community. I'll let Dr. Smith talk about sort of what all the various pieces are, but for me, that's really helpful because every time I think about a decision, whether it's in patient care or more recently in thinking about information technology, I think about our patients here on the South Shore, and how it's going to touch every facet of their care experience. But I don't know, Dr. Smith, if you have other thoughts about the IDN or integrated in general.
I was just glad you got to go first, Sam. It's a quick, it's interesting because it's not like there's absolute test that you take that says, aha, we've scored this, now we're integrated, and we're not. It's something you aspire to, and I'm not sure you ever fully think you're integrated because you always see things you could do better. But I actually prefer to sort of think about two words beginning with I. One is integrated, the other is independent. And they're very important. So let's start on the second one, independent. So we are not part of a larger system. We're pretty unusual to be this large, 374 bed hospital, plus the surround systems, which we can talk about in a few minutes, John. And to not be part of a larger system, particularly here in Massachusetts, where you've got some very large health systems like MGB and BI Lahey and so forth. And the integrated part, I think, becomes so important. And I think Sam hit the nail on the head. It's about doing what's right for the community. And when a patient comes, if they feel like there's no sense of what one hand's doing, the other doesn't know. So if you're in a primary care office and they don't know anything about what's going on in the ICU or in a pulmonary clinic or what have you, that really is a problem, I think, for patients and their sense that they're part of a system and why even they'd want to be loyal to that system. So it's a journey. I would say we've made significant strides in the 5 years I've been here, following on, and I would say I stand on the shoulders of prior CEOs. But I think we're getting better and better at being one system. But it is definitely a journey because it's a complicated system that goes, and many of the viewers may not know the geography here, but we go all the way down the Route 3 corridor, essentially South Boston, Quincy, all the way to the bridge in Plymouth.
I would just add, I think, I was thinking, I don't know, as you were talking there, sometimes it's also maybe helpful to think about sort of discrete examples. So one discrete example from that really was a system effort, but was maybe an IT centric example, was we have several urgent care sites that previously had been on a separate electronic health record system. And this year, made the investment to bring them on to Epic, bring them on the South Shore instance of Epic, which was obviously a lot of time, a lot of money, a lot of investment to bring them on. But as Alan was saying, that it allows people to go to the urgent care that's down the street, to see providers that are South Shore providers, to have tests that their primary care provider can see the results of, to be able to order imaging tests and other things at the main hospital site, all in a fully integrated way, all in a fully seamless way for the patient, so that from their standpoint, it's all one experience. And we've heard really great feedback from our patients about that, and their ability to really feel like they have this one journey that doesn't have lots of different parts. Because obviously, right now it can feel a lot of times when you're a patient. I, I fell skiing a few weeks ago and broke my arm, and just trying to navigate the, urgent care where I was, and then trying to make follow-up appointments and all those things. And I'm obviously someone who's pretty well versed in how to navigate the healthcare system. And so, for us, I think as we think about the IT piece, trying to make sure that we make things as seamless and as integrated for people as possible is really, part of the mission.
Well, and I think about that's a great example. When I think about it as a consumer, nowadays, I mean, a lot has been said about this, but nowadays, when you're buying something from Amazon, it's one click. You get into these sort of ecosystems of how you buy things, how you consume things. And there's this expectation, I think, at this point in 2026, and it's been there for a while, that healthcare should be the same way. And I think a lot of the dissatisfaction that gets measured is due to this sort of disintegration. And it's real, I could tell you, it's really hard from somebody sitting in my role, because we assess the level of integration. That's one of the things that we do, the level of integration. What does that mean? Vertical integration, technology integration, right? And yet, as a patient, I've given this example before on the pod, but I'm just going to say it again. Like as a patient going in for shoulder surgery and all the things that needed to happen for that, lifelong tennis player, so I had to have some things cleaned up. The fact that I'm giving my insurance card for the 5th time,
Yes,
really, to the same, and I'm not going to name names, but really, the 5th time I'm giving you my insurance card,
right.
That's just, and this was a system that we had scored pretty highly because on paper, you look at him stage 6 and 7, right? And all this, these super high tech, and they've gotten these awards here, and their CTO is Becker's name, top CTO, all this kind of stuff. But as a patient, it's a different story, and on how well you execute, which is kind of gets to my next question, which is how you assess the value that you're creating. I'll start, and Dr. Smith, maybe you can talk to this, how you assess the value that you're creating through that integration in the community, that independence that you talked about, where that you're building that, creating that value for patients.
Yeah, and let me come back to that, but and it's somewhat related, which is what Sam talked about is absolutely true. The IT linkages so that you don't have to pull your insurance card. But another important facet and something that I do think we do well is the respect that clinicians have for each other and our use of Tiger, which Sam can talk about. The ability to quickly reach out to another colleague to say, hey, I have a patient with a complicated issue, or I don't know what to do, or we have a trauma coming in because we're a level 2 trauma center. How do we work together as an integrated team? So I think sometimes we put too much stock into, hey, we'll wire things together, but if you don't create that culture where people work effectively together. So that's a little hard to measure, but that's somewhat that's a critical component. Where we've seen it, and we've recently been involved, I think all of our major insurance contracts were due the beginning of January, which made for a rather prolonged contracting season. And so one of the ways I think of value is how the insurance companies see value, which is how the customers see value, which is the employers or the government or the individual patients. And I do think that is, sort of the formula of quality and patient experience divided by cost. But in a real way, what are we providing here that doesn't need to go into Boston? Can we provide high-level services where if they're going to go into Boston inherently, and there's nothing wrong with it, it's fine. But if you look, and our state does publish prices on their DPH website, it's going to be anywhere from 10 to 50% more expensive. So, for example, we have a 12-bed pediatric unit and we have a 24/7 ED. Those are almost unheard of in community hospitals nowadays, and a level 3 neonatal ICU, which is the highest level. We're the only community-based entity that offers a level 3. So every one of those patients, they don't have to go into Boston and drag their kid, up through traffic and deal with all of that stress. But just as importantly, it saves a lot of money, and the level of care that we provide, and we measure it, is tantamount to what is in Boston. We also have found, and we've measured this versus the literature, that when you look at Medicare patients, the typical transfer rate of Medicare patients is roughly 3% in a hospital like ours, which is 15 miles from an academic medical center. We transfer at about half the rate. And not because they really do need to go to Boston and we're not letting them go. We really do provide extraordinary high level care, which Sam can speak about wearing his clinical hat, including in our critical care units. So I see value along that spectrum and somewhat look to the insurers as they define value.
Yeah, no, I agree completely. I mean, I think in terms of how you define the value of the integration piece, I think it's hard. I mean, I think just being honest, it's hard to put a metric to it. I think there are specific examples. I'll use one just from my day to day. So we have a standing meeting that involves people all the way, myself, folks from informatics, folks from our analyst team, where we look at our result routing errors. So one of the things that, obviously we think about a lot in terms of our integration with the providers is how we make sure that we're getting information back to the providers. When they order a test, how we make sure that it's getting back to them. And we have a lot of community providers here who maybe are affiliated with the hospital, affiliated with the system, but aren't employed by the system. And so they use our laboratory services, they use our imaging services, and the real resources for them. But we want to make sure that they're getting the results of those tests and that they're not going into some error bucket somewhere. And so, one of the things we look at on a weekly basis is what's our error rate? How frequently are we having these things show up in the error pool? Which again is not a global metric of how integrated we are with our community or how integrated we are as a system, but is one discrete measure of how well our integrations with each of these individual practices are working and how well we're doing across the region to make sure that people are getting the information that they need. I do think, stepping back sort of one level, and again, sort of wearing my clinical hat, the integration, we talk about integration as far as our system, and we are independent and very proudly independent. And it's one of the reasons that I love working here, because it allows us to, care for the community or have this clarity of purpose in a way that, I think can be harder when you're at a larger place. But we are also integrated with the surrounding community. And as Alan was saying, we don't send a lot of patients into Boston from the ICU, for example, where I work clinically, not because we don't want to send them, but because we don't need to send them. But when we do need to send them, then we have, a very clearly articulated and straightforward approach that allows us to integrate with Mass General Brigham, with BILH to get the patients the care that they need. So that's where that complexity comes in. I think we are integrated as a system ourselves, and then even though we are proudly independent, we're integrated with the larger healthcare ecosystem in the greater Boston area when we need to be, and when it's appropriate to be so.
Are those, the next topic I wanted to get into is a nice segue is into partnerships. So are those formal partnerships? And we've kind of gotten to this already, but I want to ask the question specifically: what problems do those, or were those partnerships designed to solve? Whether they're formal or not, what kind of problems are they designed to solve?
So maybe I'll start with that, Sam, and jump in. So yeah, they are formal partnerships. So our partnerships, we have really four main ones, John. Mass General Brigham, which started as the Brigham, but now it's the full MGB. Dana-Farber Cancer Center, and Boston Children's Hospital. So those are four, global names that we have, legal, contractual, strategic partnerships with. We also have a partnership with a behavioral health provider called Aspire, and they are what's called our community behavioral health center. So that's very important. So what I see it as is a win-win, which is initially these started as essentially supplying doctors. My joke is sort of like the old Sears Roebuck catalog, and I'm really dating myself to say that it was actually a physical thing when it existed, and you'd order something and then boom, here comes a surgeon. So often there are specialties, subspecialties where it's very hard to get people to want to practice full-time in the community or to get the cream of the crop. And so often places like the Brigham, where they would have a surplus of really top surgeons, they can't all be the number one or number two. So this gives them a chance either permanently to be in the community with an occasional day in Boston, or maybe they work here for 5 years and then go into Boston. So we have most of our surgery, not orthopedics, not urology, but most everything else is actually Brigham surgeons who work here, almost all full time. Our pediatric program that I mentioned, so the 24/7 ED, the 12-bed inpatient unit, and the level 3 NICU are all staffed by children's physicians. So they're employed by children's and work here. And then the rest of the staff is ours. So they're very integrated. And then across the street, and I'm looking right at it, we have a Dana-Farber Brigham Women's Cancer Center, which is huge and takes care of enormous volumes of patients. It's really a three-way joint venture. Interesting that I was involved in when I was at the Brigham, spent 2 years helping negotiate that. So these are very structured, formal relationships. Another example is when I was at the Brigham, we got a phone call that South Shore was struggling with neurology. Most community hospitals really are struggling with neurology at this point, and often do teleneurology or don't have any available. And so the Brigham built a program. We now have about 20 physicians down here. It is a gigantic program. It's bigger than many academic medical center programs, and it covers multiple aspects of both inpatient and outpatient neurology. So in some ways, we see this as the best of both worlds. What's in it for the Boston hospitals? Well, typically, if you have the relationship when that tertiary quaternary referral is needed for something we don't do here, whether it's heart surgery or complex neurovascular or extracorporeal membrane oxygenation, we will typically, our first phone call will go to MGB. Now, if they don't have a bed, we're happy to send them anywhere they can go, but it does breed a certain sense of appropriate loyalty.
I would just say on the IT side, we don't have as many sort of formal partnerships, and in fact, it's an area where there are challenges. I think we have these formal relationships with MGB and with others, and this is a place, and I think you mentioned your prior experience with surgery, but I think our patients sometimes have issues that cross institutional boundaries or institutional borders, where they feel difficulty with information passing back and forth, and right now that's a technical limitation that's hard to overcome. We certainly use all of the Epic tools, and it helps that most of the institutions in this area are on Epic. And so we can use tools like Epic's Care Everywhere and others. But there are limitations with what you can do across Epic instances. I think we sort of push the boundaries of what we can do with those. And it is helpful, but there are challenges. That said, we have been in discussions with Epic, with MGB, with others to think about, what are the latest and greatest approaches that we might be able to use to overcome some of those. There's a new tool called Epic Aura that might allow cross institution or cross Epic instance ordering that we're investigating, and other opportunities. But I'd say it's one of the places where there are challenges, and we try to be creative and think about ways of dealing with them. But with every challenge comes an opportunity. And so hopefully over the next 5-10 years, we'll be able to surmount some of those.
Yeah, certainly the technology side of things. I mean, often joke about whoever solves the interoperability problem in a simple way is going to be the next gazillionaire.
Right.
But it's interesting when we talk about your level of partnerships. It's a lot of it has to do, I think, with your geography, right? Because a lot of partnerships out there, they're about amassing size or buying power or other things. So specifically, if you were to how do I ask this question? In thinking about partnering effectively, what advice would you have to health systems that are considering specifically an academic or a pediatric partnership, rather than one that's about size, but more about capability for patients? What kind of advice what would you tell people?
Sam, do you want to take a first crack at that, or do you want
I'll let you take a first crack at that one.
I've been on both sides, John, and like a lot of these things, it really should start with a clear sense of what is the goal, what are we trying to accomplish with this partnership, not just, we just want to be, have a relationship and put their name on some plaque on the wall or what have you. So really, what is it what are our core strengths? Where do we need support? And then that's the fit. Is it an organization where we see eye to eye, where there's a good cultural fit? They're very different. AMCs and community hospitals, they're not exactly the same. Physicians make changes. Sam is a wonderful example of somebody who sort of crossed over from hardcore research, really high-end research, to clinical and now executive. Those don't happen every day, as you know, and it says a lot about Sam and his incredible versatility and intelligence to be able to do that. But I think it really is like, what specifically are we looking to do here and how can we grow it? And I will say, just to come back to the last question, while our relationships really have been, again, my proverbial Sears Roebuck catalog kind of thing, I think over time there is opportunity to think of, let's say, AI and things where we can't be a research institution. We're not going to do the cutting edge research. Could we one day participate in a trial where they're looking to see how they can change the way nursing care is delivered on the floor? We have a lot of volume here. We have typically 450 to 500 patients in a 374 bed hospital. That's a whole nother topic if you want to go there, how we do it. But we have a lot of volume that we can put into a research study that could be very interesting. And then we help with the research, but we don't have a giant research operation here, those kinds of things.
I will just add, I think from a sort of just thinking about the IT operations piece, but thinking about operations in general, again, I sort of like specific examples. We are making some changes to our mobile application management system and how people are going to access things on their phones. I was just emailing with our CISO earlier today about this, and that's going to affect the providers we have who come from the Brigham, and it's going to affect them some in good ways, because it's going to mean that they're going to be able to access Epic, both the MGB Epic and South Shore Epic from their phone, which is something that to this point they hadn't been able to do, and that actually we're sort of pretty far on the bleeding edge of being able to provide that to folks. But it'll also affect how they deal with email and things like that. And so I think my point here is that I think Alan talked about the sort of big picture, high level, sort of importance or thinking about partnerships. But there are a lot of these operational details that are also really important and can't be left to the last minute, because, it really affects the provider's quality of life, the ability to care for patients, the ability to get the information that they need. And they have to be thought about, early on. I was on a call with a group of CIOs a couple months ago, and they're one of the people who was on the call is dealing with sort of an opposite problem where there's a partnership that's breaking up, and they're trying to figure out how people are going to access information and how they're going to do cross-institution ordering. And it's a huge mess. And it was very clear that a lot of these details just hadn't really been thought about as they were thinking about the larger strategy. And I think they'll figure them out. They're smart people who are involved, but it's going to be a painful process. And so, there is the high level, what are we trying to get? What is our strategy here? But there's also the nitty gritty day to day that really does affect patient care, patient experience, provider experience, employee experience writ large, that, you really have to consider.
Sure. Vincent, this may be one of those sections where we have to cut out. But I'm going to ask the question because I'm just curious. You mentioned neurology.
That means,
Dr.
Sam,
Smith.
you're going first on this one, dude.
Right.
This sounds like, remember when he said he doesn't have zingers? Here comes the zinger.
Right. Yeah, no, I'm excited.
Honestly, it's not a zinger. It's a question that I've been thinking a lot about over the last couple of years, and I've never gotten a good answer. And that is, you mentioned neurology, and you mentioned the shortage or the lack thereof. What is behind this?
Sure.
What's behind the issue? Because I don't know. Well, I'm not a doctor, but I find neurology, neuroscience, everything about it, extremely fascinating. And I would imagine a lot of folks coming through medical school would think the same way. So what's the issue? This has been going on a long
Yeah,
time.
and I don't know that I have the comprehensive answer, but I had a little bit of a sense of it when I was at the Brigham, and I had the honor to work with the late Dr. Marty Samuels, who was chair of neurology, and he would show me actually articles about it. I think it's a few things, John. One is neurology has changed. The old neurologist, and it was kind of a joke, but they call it neurology was diagnose and adios, which means make a diagnosis and bye, because it wasn't really terribly therapeutic. It was more like, okay, I know what's causing the problem. There just isn't much we can do in terms of fixing, lesions in the brain and things like that, or even acute strokes. With the advent of much more aggressive therapies for strokes and other things, and even epileptology and things, neurologists are much more therapeutic doctors. And it's fundamentally become a 24/7 business where if somebody comes in with a stroke in the ED, a decision has to be made what to do with those folks. And so what used to be something where, okay, I can turn off the beeper at 7 o'clock at night unless I'm on call, it's really become 24/7. So I think that's part of it. I also think because neurology is such a fascinating growth area of science, a lot of the really capable neurologists would rather be what Sam was doing before, staying at an academic medical center and both participating in clinical, but also being active in research. So to find doctors who want to be 24/7 in the community is very tough. So we've been lucky, and some of our neurologists are full-time down here. Some are part-time, but I think it's created sort of a cohort where they're enjoying each other's company and they love what they do. But it is super busy. But yeah, just a quick story. My mom had a fall with a subdural, and she was at the old hospital where I used to practice at on the North Shore, and they used to have a wonderful program when I was there, fantastic program, neurologists and neurosurgeons. They're all gone. They just ship them into Boston, or it's telemedicine. So it's changed a lot, but I think it's that combination. I don't know, Sam, if you have any other thoughts.
I don't. I mean, clearly I'm not a neurologist, but I will say that I think that I agree with all of those. I would also just add that you know, big picture in medicine, it's harder and harder to practice ambulatory medicine. It's, as Alan said, it's 24/7, but it's 24/7 both in terms of getting paged about acute things and also with your in basket never stopping because you're getting messages about refills and prior auths and things like that. And neurology, for better and for worse, has lots of new and great innovative therapies. And I don't know this, and so this is a little bit of speculation, but I would imagine that their in baskets are very full with a lot of requests for refills, for prior authorizations, for expensive medications. They also take care of a patient population that has a lot of needs. They need rehab, they need chairs, they need assistive devices, they need all of these things. And so and again, this is a little bit speculation here, but I would suspect that it's the case similar to the way it is in primary care, that the amount of work that they're expected to do that is outside of the visit, whether it's outside of the clinic hours, the way Alan was talking about with acute stroke, or whether it's outside of the visit in terms of all of the interactions with insurance companies and others, I suspect that's huge. And that's a real dissatisfier. And it's hard and something that leads to a lot of burnout. Something that we've been thinking a lot here about South Shore is, how do we, and other places have as well, how do we help with provider burnout? But I would suspect that neurology is dealing with a lot of those issues, the same way many other specialties are, and that as Alan was saying, at even a large regional center like ours, they're going to be seeing a lot of patients. They don't have protective time to do research, or they have minimal protected time, and so the volume of that outside of the visit work is going to be massive, I would imagine, and make it really difficult from a work-life balance standpoint.
Well, thank you for thank you for your speculation. It's just, again, as I look at different specialties,
yeah,
it's just this one area. I mean,
it's a real problem.
It's a real issue. So I have one other topic I wanted to make sure that we got to. sort of the flavor du jour, but I think you guys have something interesting to say about it, and that's AI.
Yeah.
And specifically, what I want to know is, how is AI implementation, AI usage, how is that different in the community setting? Because I normally think of this, and when we've written about AI and partnerships that people have had, it's usually the big academic systems, right? So how is it different? And you know, I'm thinking of the word culturally. Maybe that's not the right word, but what is the community, the physician community uptake and the usage of AI in kind of that community system versus in an academic system? I know there's like 6 questions in there, all wrapped in one, but
Yeah.
really, I just want to know your take on AI and the community systems.
At the end of the day, we're looking at off-the-shelf solutions, and so because of that, we're really trying to think about what are the off-the-shelf solutions that have an ROI, and what is that ROI? And that ROI might be patient safety, it might be hard dollars, it might be provider well-being, but something that's going to provide some sort of benefit. Um, we do that through a few ways. One is we do have an AI governance process with an AI committee that reviews all of our new AI tools. I'd say it's hard because everything these days is an AI tool. I'll give an example. We in the ICU, I happened to be on service a couple weeks ago and noticed that we had a new ultrasound machine that we were using that is great. It's fantastic. I'm very appreciative of it as a provider. It has AI built into it, and it hadn't gone through our AI committee. We have since reviewed it and made sure it's safe and made sure that we're not doing anything untoward. But it's hard to keep up right now because everything is AI. The big things, though, the ambient dictations, the things like that, that all goes through our AI committee, which is made up of folks both from IT, but also from direct patient care. So we have providers, we have nursing leadership, and we also have people from quality and safety to make sure that we're evaluating each individual tool and making sure that it's safe, effective, et cetera. As far as uptake goes, I think it's like any new technology. I was giving a CME talk a few months ago and talking about AI in medicine, and someone asked the question, well, with this new diagnostic tool, are providers not going to be able to do physical exams anymore? Are they not going to have any knowledge? If they use open evidence, are they going to forget everything they ever learned in medical school? And um, circling back to our neurology example, I think I'm sure that there are neurologists out there who've been practicing for a long time who would say that current neurologists' ability to diagnose exactly where a lesion is in the brain is far worse now because they don't rely on their cranial nerve exam skills the way they used to. That said, I don't think any patient wants to be told, we think you have something in your midbrain, but uh, we're not going to use the MRI because we're worried that the provider's skills are going to atrophy if we use the MRI to confirm it. So we're going to treat you based on this physical diagnosis alone, right? So I think it's one of these situations that as the providers see the benefit and see the improvement, and as we demonstrate to them that ROI, especially for patient outcomes, then the uptake will come. We do have a small pilot that's ongoing with ambient dictation, and we're actively working to expand that to all of primary care. And part of the reason we're actively working to expand it is that the 20 providers that started using it, now granted they volunteered for the pilot, maybe they're a little bit more likely to be early adopters. When they heard that we were going to expand it and that we may or may not be changing vendors depending on pricing and all these things, they said, okay, but you're not taking away what I currently have, right? And they were very worried that it might disappear, and they couldn't really imagine getting rid of it. So that's you know, maybe a lot and a little all at the same time, and I'm happy to go into more depth about all of those. But I think fundamentally we are different. We're not going to be developing our own tools, but that doesn't mean that we can't use the tools that are out there. And it doesn't mean that we can't leverage them to get the highest quality, best care possible for folks. At the same time, being cost conscious, and maybe that's worth also talking about. I think one challenge, and I was talking about this with our CMO the other day, is people talk a lot about AI being able to not necessarily replace people, but make people more efficient. Make people be able to do more. And we're at this inflection point where we need to start paying for these tools, which have real costs, real dollar costs associated with them, before maybe we see that benefit, before we see the ability to do more, before we see the ability to maybe get rid of some outsourced costs that we currently have. And so we are a little bit, and I think we're not alone in this place where we see costs rise related to AI, and we don't necessarily immediately see the cost savings. We have that little hump we need to get over. And that's something that we're actively working through and thinking about, and part of why we have been trying to do things in a measured approach. But I mean, I would say that, we feel pretty strongly that AI is important and that we want to, move forward where we can, while also understanding that we have to be thoughtful about it as we go.
You mentioned AI is everywhere. How much of it these days, especially in your role, um, is really AI? I mean, do you get a lot of this slap things that would have been, decision support 10 years ago or 5 years ago? Now all of a sudden that it's AI, right? Or is it truly that the kind of techniques and things that are being built out, that there's that kind of common background?
Yeah, I mean, I think it's hard. I think part of it is whether is how semantic you want to be about this, right? Like at the end of the day, um, you know, what what are we going to use as our definition of AI? What are we going to use as our definition of machine learning? I mean, in truth, right? Like quote unquote AI or machine learning has been around for decades um, in medicine, right? I mean, the top of the EKG with the preliminary impression, right? I mean, that's been around for a very long time. Um, I think it really is everywhere, right? I'm looking at my screen right now. I have echo cancellation turned on, right? That's AI. That under the hood is an AI signal processing tool that's reducing the echo in my background, hopefully effectively, if you can hear me. Um, so I do really think that it is everywhere, and for better and for worse. And we'll just sort of have to see how things evolve.
Sam, can I just jump in? Is it also worth talking because as an independent system, we're typically not going to that cutting edge VC backed company that may not, frankly, be around in 2 years. So, how do you choose the firms with which we're working, Sam?
Yeah, I think that's a great point. Again, we are trying to be thoughtful about who our partners are, and there's a tension there, right? Because we want to make sure that our patients and our providers and people who are using things have the access to the latest and greatest, while simultaneously, as Alan was saying, make sure that we're working with folks who are going to be there in 5 years, and that we're not constantly having to do implementations, because our entire um, IT team is less than one-fifth the size of the largest academic um, AMC in Boston, their Epic team alone. So, for us to be able to do repeated implementations is just hard. Um, so we try to, whenever we're thinking about a problem that we're going to try to solve with AI, we try to look to the Epics of the world, the Microsofts, to see if there's a potential solution. Now, sometimes they don't have the right solution, sometimes, or they have the right solution, but to be very blunt, the cost is really high. And we have to think about other opportunities. And there we try to really lean on our our sort of, I'd say, friends and colleagues. I think one thing that I would really stress, especially as someone who's only been in this role for 6 months, is, and this circles all the way back to your integrated question. I do feel integrated with the healthcare system writ large, right? So like when I'm thinking about, selecting a new vendor, et cetera, I would say that other health systems are incredibly generous with their time and expertise. And one of the things that we do a lot is we go out and we talk to other customers and ask them, what's been your experience with this vendor or that vendor. And we spend a lot of time on reference calls to make sure that we're selecting folks who are going to be good partners for us. And I'd say that the CIO community in general is just incredibly supportive and helpful, and it's been a great resource in thinking about how we, move forward in this area.
Well, last piece. I got to think how I want to phrase this as well, but I'm going to go back to the beginning. We talked about the independence of South Shore, and the way that you described it, Dr. Smith actually is very proudly saying that you're that independent system. And when I think about this sort of notion of bigger is better, the common spirits of the world, nothing against common spirit, but, we look at that merger, it's one massive health system and another massive health system. You look at Ascension and HCA, right? But there is a role. There is a role for this, I guess, the future of the independent, the smaller system, the nimble system. So I guess maybe my question is, help us understand what you see the future of these community health systems and these independent health systems in this complex sort of mosaic of healthcare going forward.
No, it's a great question. And I think this is one that's just being written over time. We've actually explored acquisition in the past, and it didn't work out. So we've been sort of down that path. Fortunately, our board recognizes how valuable it is to be independent and the decisions that we can make, the programs, the kind of things. I'll give you an example. So we mentioned how busy we are. We've had 3 former Steward hospitals close in the region. And then on top of that, in February of 2023, Brockton Hospital, which is a wonderful disproportionate share hospital serving about half of the Brockton community, had a gigantic electrical fire and closed for 18 months. And we made the decision right away that we were going to do everything we could to serve as much of that population as we could, along with the other Brockton hospital called at that time Good Samaritan Medical Center. And so the ambulances started coming. We had to hire 120 travelers right away. That was at about they were costing about 120 to 130 an hour. So it ended up being about a $250,000 per nurse to hire these travelers. But if we didn't do it, we wouldn't have been able to serve the community, and we would have crushed our staff. And at the end of the day, I keep looking at it very simply, and you kind of hear that with Sam. We're about what's best for the patients and families, and we're about what's best for our colleagues and the providers. So we had to do those things. I think a larger system would have said, no, we're not going to help. We're just going to, and somebody else has to pick up the tab here. Well, unfortunately, we lost about $25 or $30 million. We were hopeful that the state would have reimbursed us. They didn't. It's sort of water under the bridge at that point, and I don't raise that to try to solicit sympathy, but it's an example where as an independent system, we could make the decision. At the same time, we've also had to close some programs. We stopped our hospital at home program because it just wasn't working out. It was probably premature. So we've been able to make those decisions. Will independent systems survive? I sure hope so. And we're doing everything we can. I think we have a great management team and a great board. I think when I look at the one big, beautiful bill and the challenges that's going to face, in some ways it seems harder as an independent. On the other hand, I think we can be much more flexible and agile as a smaller system. And that's our hope. I'm investing right now, and Sam's part of it. Even though we're super busy, we're actually taking time once or twice a month to work with the senior team to grow as a team. That my view, and I think we see it when you use the football analogy, John, is the teams that will ultimately win that Super Bowl are not just the best on paper by talent. They're the teams that really do function as a team, and where their coach and their management have understood that it's all about teamwork. All I look at is, I'm a Pats fan, but look at what Mike Vrabel's done to turn that team around. And it's all about teamwork. So we're making those investments that you can't do as a larger system. But I can't guarantee the outcome, but we're going to fight like hell to maintain our independence, to be honest with you.
I think the only thing that I would add is is two things. One, in terms of the future. I mean, I share Alan's feel. I hope and I think that it's bright. And I think that for two reasons. One is that I do think AI is a great leveler, right? I mean, I think that we have access to, with the addition of technology, an opportunity to really level the playing field and provide, I think we already provide equal quality or better care, but we can access, more information, more tools, et cetera. So I think that's, one big piece of it. And then, and I'll be careful saying this because I don't say it in any way to malign where I was before, because I loved all of my time at the Brigham and think it's a fantastic place, and still have many great friends there. But one of the reasons that I love being here is that I understand every day when I walk in exactly what we're trying to do, which is care for the South Shore, both including our patients and everyone who works here. And I didn't always feel that same clarity of purpose before. And I think that clarity of purpose in times where, regionally, nationally, globally, there's a lot of upheaval. That clarity of purpose, I think, is really helpful, and I think allows us to really focus on what's important. And when we make, tough decisions, like Alan was talking about, it allows us to make sure that we're making the right tough decisions. And so I'm hopeful. I think that for that reason, the future is bright here, acknowledging that it's going to take a huge amount of work and that in some ways the deck is stacked against us. But I think and I hope we're here for the long haul.
Well, I want to thank both of you, Dr. Smith, Dr. Ash. This has been a really thoughtful conversation. I really appreciate your insights. Hope to have you back in the future.
Sure.
This has really been great. As I said at the onset, we don't always get this kind of a window into an independent, community focused health system, especially one that sits kind of in the midst of all the activity where you are, right? So it's really nice to get your perspective. I really appreciate it. So thank you very much.
Thank you for having us, John. We greatly enjoyed it.
No, thank you. This has been great.
Well, that'll do it for another episode of Healthcare Rounds. Please make sure to rate and review if you like what you heard, and we'll see you next round.